So now once we are done with the history and the points that we particularly are focusing on when we're looking at a patient of abdominal pain, we must know how we must proceed with the physical examination of the patient. As we all know, we basically divide the abdomen into 9 quadrants, basically 9 portions. We have the upper quadrants and we have the lower quadrants. We have the 3 upper, the 3 lower, and the 3 middle quadrants. And we usually even perform the examination accordingly. Whatever examination we are performing, we'd be performing them in a particular pattern. Particularly, we usually perform it in an S pattern when we are looking at the particular patient and we're looking or examining the abdomen of the patient. Now, the particular essentials of the diagnosis over here would consist of an inspection, first of all. So you would basically, first of all, inspect the patient. The visibility is very important. The lighting is very important. And you would basically, and first of all, you ask for a consent. And this is the prime factor before any examination to carry out. You would be basically explaining to the patient what you're about to do. And either you're starting an inspection or a palpation or percussion, you have to basically take the consent and educate the patient regarding the fact that you're basically going to do this particular act and either it is going to hurt or not. This consent is very, very important that you have to focus on. When you're looking at an abdomen of the patient, obviously, you look for the normalcy of the umbilicus. You look for the normal factors that are present in the surroundings. And then one important thing that you're going to focus on is the surgical scars. It's a routine practice that when you usually ask the patients, particularly the older aged individuals, and when you ask them that whether or not they have undergone any surgery, and sometimes they would give you a history that they haven't. And when you look at the abdomen of these patients, you would find out that there are multiple surgical scars. So it's basically upon the inspection of the physician himself or herself. And once you take the history in detail, you're done with that. But you'd move on and inspect in detail the abdomen of the patient as well. Then again, you would basically look for the other factors as well, as these days the surgeries are quite modified and there are basically the endoscopic kind of surgeries that are being performed. So these scars are not quite evident and they're usually put on areas in which they're not quite visible, for instance, around the umbilicus. So you'd look for these factors as well. Moving on, we have auscultation. We usually perform auscultation before palpation. In case of abdomen, this series is being performed. You auscultate the abdomen and you basically are looking for the bowel sounds. And if the bowel sounds are not heard for even a complete 30 seconds, you usually say that the bowel sounds are not present. So this is how you basically auscultate and you see whether you're hearing or whether you can hear the bowel sounds properly or not. So this is again a very important step that you have to perform. Then palpation is again very important. Palpation is of course of 2 kinds. First of all, we perform a superficial palpation in which sometimes some patients, for instance, patients suffering from pancreatitis, they would have an extreme kind of tenderness. So even on superficial palpation, they would be having an extreme tenderness and an examination would not be possible. So basically you first of all perform a superficial and then a deep palpation is carried out in an S pattern again. Even the auscultation is carried out in an S pattern. Percussion of the abdomen, when you dab the abdomen, is again very important. And again, it's carried out, particularly you dab the abdomen 3 times in each quadrant or in every quadrant. All of the 9 quadrants are basically particularly very important when you're carrying out these particular examination. When you are doing this palpation and this percussion, it's one way that you're even looking side by side and you're assessing how much tender the abdomen is. And when you stop palpating, when you are basically carrying out the palpation and the patient is not having any tenderness, and when you stop palpating and he or she complains of tenderness, it's one way of checking the rebound tenderness. So it's one of the things that you'd be looking for and you'd be noticing for. Infrequent bowel sounds is one of the factors that you'd be looking for when you are auscultating the abdomen. So sometimes you hear a very feeble kind of a bowel sound. So that can be basically termed as an infrequent bowel sound rather than an absent bowel sound in the individual.